Thank you very much, and thank you for the invitation. It's a great pleasure to be here and to be able to talk to you about some of this work. And the work is going to be focused on, as the title suggests, the exploring the potential, the utility of the advances in mobile health technology. So that's things such as wearables and phone devices. And so just before I do go on, I'll just declare a couple of interests. One of them being in Onsentia, a small startup company which is focused on mobile health, and also Cogstack, which is an AI company focused on processing of text within electronic health records. So as we know, we're all carrying around wearables or wearing wearables and carrying around mobile devices. This pretty much ubiquitously now. Everybody has these devices. We're all wearing them. We're all generating huge amounts of data every day, 24/7, through just having these devices either in our pocket or on our wrist or otherwise attached to us. And so this presents a great opportunity potentially to think about how we can shift health and healthcare to take advantage of this data that we're generating, these data streams that we're generating 24/7. And so if we think about this, the typical kind of paradigm within which we have to work within health and healthcare is we have these data that are we have access to periodically and sporadically, and it's intermittent, and it's usually when somebody is ill rather than in a period of wellness. And so this presents a challenge in terms of thinking about prevention, for example, but also, it just means that we have these kind of sporadic contact points where we have data provisioned or given to us about or by the patient or by the care team. So we have these massive holes. In research studies, we might be able to collect more kind of regular data and get more data from people, but it's still vastly kind of suboptimal in terms of thinking about how we might be able to move towards a model where we're able to collect data much earlier, to be able to assess risk much earlier, to be able to collect and detect early diagnoses, and to be able to collect data through diagnosis and to manage disease, and to be able to track people's trajectories and people's response and people's relapses, and how people are complying with their kind of healthcare. So this is what we think, or the hypothesis is that wearables and smartphones and these mobile technologies might be able to help us shift from this first scenario to this last scenario, and therefore, make a big difference in how we look after people. And of course, with governments in the UK, there's a big shift in the priority towards shifting towards care in the community, care outside the traditional healthcare setting. So these kind of technologies, could potentially really help with that. But we have to kind of understand what is good, right? Or what is acceptable, what the thresholds are for something being useful. And are these technologies sufficiently good enough and accurate enough to be able to do this? Well, if we think about a use case such as epilepsy, and we think about what we have to improve on there to generate something that could be good or something that could have utility, we have this paper here reports a study where they did a comparison of EEG against patient-reported detections of seizures. So patients reporting when they felt they'd had a seizure versus clinically derived or clinically generated measures of seizures. And you can see there's very little correlation here. So if we're doing studies in epilepsy, whether it's trials or otherwise, we're going to be dependent on patient recall, typically, outside of their clinical setting. And we can see that creates a massive problem for running trials such as epilepsy in real-world settings. So that's the kind of benchmark that we have to kind of better, I guess, or the threshold that we have to work against and improve on. So we were kind of quite encouraged by that, I guess, that kind of, we saw that as a big opportunity about 10 years ago. And our first study was really not on epilepsy, actually, but looking at sleep and looking at sleep in patients with psychosis. And this was a study done by recruiting people through clinical services within South London and the Maudsley, NHS Foundation Trust and mental health service provider there. And we were, we decided to study sleep because obviously there's a large, a strong, well-known association between sleep and psychosis. And people after having first episode of psychosis will typically relapse within a year, find themselves in a crisis situation, appearing in our services, in a critical state. And they will usually report, or the carers will usually report sleep as being one of the indicators or one of the symptoms that they saw first or experienced when they started to relapse. So we started to look at sleep, and we used a very basic device at the time, a Fitbit Flex, which was just basically capturing HR. This is an example of a patient in the bottom left, and just their raw, as raw as you get, data from the Fitbit Flex over a number of over a 24-hour period. It may have been more. And then this is the same person, but this is when they started to relapse. And so you could see it was quite encouraging to see that there's very clear, stable data here, and very clearly obvious change in data here. And so we started to think that this is really encouraging. But a major finding of this was also the feasibility aspect of this. So to what extent people were happy to wear devices, provide data, to provide the passive data, but also to provide and give data through the phone. And, we thought that this might be a difficult population to work with, being a psychosis population. But actually we found that they were very, very engaged. This is work done by Nick Mayer and our team. They were very engaged, and actually they found it extremely useful to be able to track their sleep and to be able to self-manage, essentially. So one of the major findings of the study was the self-management benefit of people being able to kind of get a sense of their own state, and then to be able to ascribe that back to to how their sleep had been changing. And that was very encouraging for them, and they could self-monitor and self-manage. So we then started to think about, the many other uses of data that could be derived from these sensors beyond looking at heart rate for sleep. And so, through the sensors on the phones that were emerging, through the sensors on those devices and other devices, we could start to build up a complex view of participants in studies. And there would be, we could get measures of sociability, of quality of life from these various data streams. And so we built out a kind of capability, or wanted to explore a capability to be able to collect this data, whether it was kind of homestay, quality of life, social contact, speech, and across a range of disorders. And I guess our next major kind of foray into this, after thinking about that, was another large European program similar to TIMESPAN, but this was called Radar CNS. So this was about 2017. And the idea was to explore the utility of these devices for MS, epilepsy, and depression. And so in exploring this, we're thinking about how these different data modalities might be able to detect relapse early on, but also to be able to track symptoms over time, and to be able to, in the case of epilepsy, track seizures, but also predict them. And so what we needed to do was kind of develop the capacity to be able to collect all of these different data streams, all of these different modalities from these different sensors on these different devices, and do it in a way that worked for Radar CNS, but also could be reused. So we wanted to develop a generalized platform that had utility beyond MS, epilepsy, and depression, because there's clear utility for these kind of measures, not just in MS, epilepsy, and depression, but across the range of disorders. The kind of many kind of transdiagnostic aspects to those measures and could be used across a range of conditions. So we focused in on developing a platform that could collect the data across from various different sources, whether that's from a wearable or third-party data API, or from phones and passively from the phone through the sensors, or actively through questionnaires. And we wanted to collect that data and then provide it to various different stakeholders. So these different stakeholders being researchers, being clinical stakeholders, participants, patients, and also, feeding that information back to them, and possibly intervening. Although many of those early studies were not focused on interventions, they were non-interventional studies where we were just collecting data through, and then care was being provided as normal. And I guess one of our motivations for developing a platform which was generalizable and could be used by the community generally and was extensible to other conditions was the fact that within the landscape, there wasn't really much in the way of a platform that could be used flexibly, and could be repurposed for different conditions. There wasn't much in that space, and there wasn't certainly much in the open source space. So we set about to develop this platform, which is really a complex system of applications, really. I guess the critical components to note are that it is open source, that it is modular, extensible, based architecture. So you can plug in or develop plugins for new devices as they emerge easily. You can customize some of the active questionnaires. You can integrate third-party apps into it. But it also has the capacity to be able to undertake real-time data streaming and process that data and do various things with it. So across various different studies, we've integrated a range of devices, including the devices that we're using in TIMESPAN. And this includes apps and various other things. It also includes Internet of Things capability, sensors, so we're able to track kind of environmental measures as well as those directly attached to the participant. And so it's easily customizable and configurable. So if you want to do EMA, or you want to set off notifications for certain questionnaires or clinical assessments at specific times, that's possible to do that, as we've done within the studies here. But so our first real kind of study after developing this and as part of the RADAR CNS was to go back to that epilepsy question about whether we can collect data and do it better than patient recall. And so this first study involved us setting up in an epilepsy monitoring unit within King's College Hospital, and where we had video and EEG being used as part of routine monitoring. And we set up a radar-based platform within those units, and we put devices onto participants. And those devices included the Empatiker E4, so a kind of earlier version of the device being used within Art Karma. And we collected data from these wearable devices, and it was all synchronized with the business as usual video and EEG. And then we looked to see whether there was evidence within the sensor data to see whether it tracked with the clinical, the video and the EEG data detection in terms of detecting seizure onset and tracking it. And it did. So particularly looking at things like electrodermal activity and blood volume pulse, we were able to see that there was kind of clearish signal in the data for detecting seizures. And at this particular time, we were also asking the participants to recall or to describe when they felt they'd had a seizure. And in many instances, they were not remembering having a seizure, not knowing having a seizure. Yet the signals here were clear to see in the clinical streams, but also in the wearable stream that we'd attached. So that was great, but that was in a clinical setting. And what we really want to be able to do was to be able to take these devices out into real world settings. And so we had the added complication of thinking about how these devices work in those settings, but also keeping people engaged with the program and with the studies. Okay, so within mobile health, it's well known that you have this honeymoon period, and probably many of you who wear devices have experienced similar, where the novelty of wearing a device or being part of a study can wear off quite quickly. We've all kind of worn Fitbits for a while and then dumped them at various points, I'm sure. So we wanted to look to see how well we can engage people and keep people engaged, and also what aspects of the study kept people engaged and people were most interested in, or kind of generated data for the longest through which particular strands. And when we're thinking about those strands, we're looking at wearable data, looking at the phone data and the passive sensors on the phone, and then the phone active data in terms of the questionnaires or things that people were consciously having to enter. And as you might imagine, the Fitbit passive, the phone active data, people tended to drop off that sooner, but people tended to drop off the phone passive even quicker, even sooner than the phone active. But the best data type or data stream, if you like, was from the wearable data, which only required charging. So people were very happy with the Fitbit. The active assessments, okay with that. We thought very carefully about the kind of load that we were going to put on people through the active assessments, and we'd kind of adjusted the protocol numerous times, particularly around the EMA. But the phone sensor data was something that we'd not kind of managed as well as we should have done. And so there were sensors. We decided to collect a lot of information, gyroscope, for example, and this was just nailing the battery on the phone. So we had to kind of design or rethink and pull out some of those sensors, reduce the frequency of some of those data points that were collected from the sensors on the phone. But there was a lot of useful information that came through this. One of the things was that the least engaged group had the highest depression symptom severity, as you might imagine. So actually, just whether you're engaging with the study is actually a pretty good predictor of your state of depression. And I should have just mentioned, actually, this was the depression study within RADAR CNS. We looked at various kind of factors that we did have, and age was this. Younger people, males, and those with higher number of comorbidities were more likely to disengage. That was actually a finding. Just checking my notes here. The least engaged group also took longer to respond and complete surveys, and were younger compared to the most engaged group. And I think another thing to think about possibly is that we were very careful to make sure that when we recruited a representative population, but actually thinking about how that population engages is something that we had to be aware of as well. So you might get certain kind of socioeconomic status groups or ethnicities dropping out over time, so that you're left with a non-representative cohort in terms of the cohort that's left engaging in your study. So something to kind of be aware of, not just who you recruit, but actually how they engage and continue to stay with your study. So we spent a long time thinking about the various kind of design strategies for building these programs and developing them in such a way that they were very much co-designed and co-led with participants, and that contributed to much greater and stronger compliance and engagement with the studies. And that was a big part of the findings, actually, beyond whether you could just detect a signal, was actually what are the strategies and for developing and the frameworks for developing these kind of projects in a way that's going to be something that people want to engage with. Of course, it's critical to be able to understand when you're getting to a point of losing people, whether people are staying in, whether people are dropping out. One of the things we thought about was kind of having a break in the protocol so that people could have kind of holidays or protocol holidays and then jump back into the studies. So there's all kinds of ways to be creative, I think, when you're thinking about keeping people engaged and part of the program. Then, of course, the next big challenge is to think about what we do with the data and how we go from collecting raw data or data processed by the device manufacturer, often, how we go through these various different levels to get from the kind of source data, low level of features, through to high level features. Okay, and so there's various different kind of analysis steps that we need to go through in order to be able to create these high level digital markers, which we can then compare against our outcome measures, and test for utility. And I guess just to go through a few of these, again, in the context of depression within the radar study again, this is thinking about how we use the GPS data that we're collecting. So this is obfuscated, the GPS, so it's offset. So we don't know exactly where people are. There's a regular offset set to the GPS. And so we can't say so-and-so's at a train station because we've had to apply this kind of shift. But we can still tell a lot from this data, which is still kind of privacy protecting or preserving. And just by looking at how these points cluster, you can get a good sense of how much time somebody's spending at home once you've defined a kind of home position. And you can also generate a whole bunch of other kind of useful metrics that includes what kind of location variance somebody has, how much time somebody's spending moving, the distance somebody's moving, the number of different places that people go to, and a whole range of kind of useful metrics. Added to that, and possibly combined with that, is thinking about the Bluetooth connections that your phone is trying to make. So whenever you go anywhere, your phone will, if you have Bluetooth turned on, will be scanning the area to see what devices are in the area and what devices it can create or make handshakes with. And this is particularly useful for getting a feel for how somebody is potentially being sociable. So typically, the large number of devices when you're going out and being sociable that your phone is trying to chat to or make a connection to are other phones. And so you get a very kind of good signal or good indication of how sociable somebody's being just by how these nearby Bluetooth device counts change over time. But also how regular these are can give some indication as to how kind of behavior is changing over time. And so we did this again in the context of depression, looking at this. And what we haven't done yet is combine the two things together to get a better handle on sociability. But this in itself has been quite interesting. That's sociability, of course, sleep. Looking at that in combination. And so this is just an example of one person's sleep record and combining. So we're looking at PHQ-8 scores and then various sleep features and looking how the PHQ-8 record changes over. We're collecting these every 2 weeks, and then looking to see how sleep tracks with that. Ideally, we can see clearly that there's some measures of sleep here that track very well. What we really wanted to be able to do was be able to detect or to see the PHQ-8 change, and then really to be able to look back in time a little bit to be able to see, or we wanted to be able to see evidence of a change a little bit upstream. And the gait was another thing that we looked at. This was using the accelerometry data from the phone. Again, some useful metrics there, or findings there where high depression symptom severity associated with lower gait cadence of high performance walking. So that's faster segments with faster walking speed over a long term. And this was work done by Yuzu, who's a very kind of prolific in terms of the analysis he does on the data, and he's also working now with Yona and team on some of the Art Karma data. Another of Yuzu's papers actually was looking at how these kind of behavior changes, the sensor changes, and the symptom self-reported changes change according to season. And so this is multi-level mediation analysis, taking the weather data from the local area of each participant, combining that with the physical activity data and the depression scores. And so here we hadn't collected information on weather directly, but we knew where people were based on the cities that they were recruited from and their, the kind of how far they'd moved around. And so we used the weather API to retrospectively go back and pull in weather data for their area, and then to combine that with the activity and PHQ data. And so we found that there were 4 basic clusters in terms of how people's behavior changed and how their symptoms changed in terms of behavior, in terms of activity, according to the season. And we saw 4 distinct seasonal patterns in depression severity in our cohort. And one of the subgroups showed stable depression levels throughout the year, one of those. And then this was looking at how in a subgroup of positive correlation, so a subgroup of people that kind of got depressed or got more depressed when it got warmer. Together, when we kind of broke this down, we found that temperature is not significantly associated with daily steps. But in the negative correlation group, we found that temp going up, steps going up, and temp going up, PHQ down, and steps going up. Together, those created meant that there was a positive relationship there in the negative correlation subgroup. So that's the subgroup that was that kind of became less depressed when the temperature increased. And I guess the point there to think about or to add in is that I think kind of bearing in mind when we're kind of doing these studies or maybe moving into trials and looking for the effects of various kind of factors, whether that's maybe a medication or an intervention, is we have to kind of should factor in things such as these kind of seasonal effects, which seem to be having this effect that we need to factor in and address or account for. So a big part of the ability of the work that we're doing in this space, and I think one that's got real potential, is around voice and speech, and being able to collect that and be able to analyze that as well. And so this is speech in the kind of ambulatory setting, again, in the real world setting, collecting speech through the phone. And again, we did this in radar CNS and do this in a range of studies, including some of the ADHD studies. And this is collecting and understanding not just what people are saying, but how they're saying it. And again, just an example sticking with that depression example, we were collecting speech from people. We were collecting both a scripted speech and a speech sample where we asked people to describe or talk freely about something that they were kind of looking forward to. And we were doing this across our various sites, so covering various different languages. And we were seeing that actually it's quite an interesting signal that seemed to be kind of language agnostic, that was sitting across or replicated across the different languages. And basically, regardless of language, participants spoke more slowly and quietly with increasing depression. And then we also wanted to, of course, in the free speech task, think about how not just how people were speaking, but what they were saying. So again, this was using the speech that had been collected through the radar-based platform, but then this was using Whisper, OpenAI's Whisper, so one of the good voice to text or audio AI foundational models at the time. And then we're using some NLP, BERT topic in this case, to understand and characterize what people were talking about. So this is kind of picking out the topics that people were talking about. We found that a number of high-risk topics for increased symptom severity, kind of as you might kind of imagine. People talking about no expectations that they had for the next few weeks. People talking about sleep. People talking about mental therapy, studying, coursework. And then maybe the slightly surprising one there was haircut. We still don't really know what that one was about. That could possibly have been, it was during COVID, some of the studies. So maybe, people were getting depressed about the fact they couldn't get a haircut. Yeah, so maybe they'd had a bad haircut from a family member. I don't know. Yeah. And so we wanted to then have a look at speech topics, see whether those topics were associated with any of the kind of any of the wearable data. So it's interesting, and we kept the high risk group there. Interesting that to see that that participants kind of talking about sleep had been having later sleep onsets and higher sleep variability in the time leading up to that kind of assessment. So they'd obviously been kind of experienced more disturbed sleep or kind of changes in sleep, and then they end up talking about that in their speech task. And people that were talking about the high risk topics generally took fewer steps than participants who spoke about non-risk topics. But this is still quite early days, I think, in terms of the analysis and the exploration of this space. Coming back to COVID briefly, it gave us the opportunity to look at the data that we were collecting and during that rather special time. And so we had a number of studies that were running at the time of COVID, with radar CNS being one of them. And so we started to look at just whether the data that was streaming in at that particular point was providing useful information. And so looking across countries, we were collecting details on lockdowns, on rollout of vaccine programs, on various other things, and then kind of plotting these kind of the kind of data streams against these various things. So it was the first Chinese communication with the WHO, first EU confirmed case, first EU lockdown, migration announcement or mitigation announcement, national recommendations, national lockdowns, easing of lockdowns. And it was really nice and interesting, I think, to be able to see almost in real time these data streams coming in. It gave us a real good handle, almost as a kind of warning system or tracking system for how these interventions, these non-pharmaceutical interventions, lockdowns, for example, were being adhered to over various different countries and how it was changing behavior. So looking at things like social app duration. This is the number of confirmed new cases, by the way, in different countries. Social app duration, so how long people's phones were being unlocked for, people's heart rate, people's bedtimes, people's sleep duration, number of new Bluetooth devices. So going back to this, you can see that, obviously people were, social patterns were changing, the steps, people were changing, distance people were traveling. So back to those mobility measures, matrix and the home stay. And so I thought that was quite interesting. But this also, COVID gave us a great opportunity to kind of start a new kind of study as well. And this involved a citizen science type approach. So rather than recruiting through clinical services or recruiting from existing cohorts, we basically partnered with Fitbit and we reconfigured one of the apps to be able to get people to self-enroll into studies and to be able to link in their existing wearable device. And this meant that we could collect large amounts of data at low cost with people's existing devices. And we got about 20,000 people through advertising within the Fitbit app sign up to enroll within Radarbase and link their data. And that was amazing to be able to do that. And we actually did that on a shoestring. One of the great things about that was not just because it was people's existing devices, we were able to collect data from retrospectively as well as prospectively, which meant that we could get all of the data from them from the point that they'd actually put that first device on. We didn't, unfortunately, have the labeled data, obviously, because we could only get that going forward, but it gave us a fantastic opportunity to generate a baseline, sometimes over years worth of data for each participant. And we've, in a study called Health Research from Home, with the Medical Research Council, and Will Dixon from Manchester and Callum Stewart from our group here, and Amos Falarin, we've been developing this further, and now we're able to, this is particularly important for a study that we're doing here, which is around knee replacements. And what we want to do is to be able to understand physical activity before and after joint replacement. We can't go back in time for those, in theory, for those people as they're before or much before their knee replacement surgery. We can collect the data afterwards, obviously. But if they do have existing devices, we now actually can go back in time. So we can enroll them into the study, generate these long understandings or these long periods of knowing about their behavior. And this creates really nice opportunities for new or different types of approaches to analyzing the data. So when you have this long norm, this baseline, you can then use AI approaches, in this case, LSTM autoencoders, to understand and track what's normal for an individual, and then to be able to model when the data stream strays out of what's normal for an individual. And of course, that then we're really interested in those particular periods and understanding whether those periods are associated with a clinical question of interest or an outcome of interest. And so this is looking at, in that same cohort, using an LSTM autoencoder trained on normal period data from 2,000 participants. So, and identifying about 400 anomalous episodes from 341 period participants, and then being able to predict kind of anomalous periods, and we've been doing that in the context of anxiety and depression within that COVID collab data set. And this is one of Heat's slides here, back here. So this is some work that Heat's been working on. So this is, as well as being able to detect things detect those anomalies, is to be able to then trigger a notification back to the participant. In this case, we're doing this in COPD within 2 hospitals. And what we wanted to do was be able to track respiratory diseases when people were at home, and to be able to detect when they're experiencing exacerbations. And so we had a base model trained on some baseline data, and then we had various devices attached to them. We had kind of gold standard measures as well as the kind of Garmin device, and we were able to track and detect at these anomalous periods. And then if we detected an anomalous period, we'd then send out an alert to a participant, ask them to complete an exacerbation rating questionnaire, and then we collect that and we use that to improve the algorithm. So it's kind of learning on the go. And that, so that exacerbation rating scale assessment was sent out in real time based on real time analysis and analytics of the data. So just quickly to as we're at this at TIMESPAN, we have to mention some of the artwork that Yona's lab has been leading, and we've been collaborating on and helping and working with her. So we've got 4 studies either on the go or completed. And the first one was Art Pilot. I won't go into too much details on these because I think others will. Heath will be talking, Yona and others will be talking about this. But Art Pilot was the first study we did. And these have been done in collaboration with Informatica and Aura. And that was a simple case control study. And then Art Transition is an MRC funded project, which is looking at transition age young people with ADHD. Art Karma is looking at, as you know, cardiometabolic risk factors in adults with ADHD. And MARM is a project with Jess Agnew-Blaze from QMUL. And here we're looking at how how different symptoms are in women with ADHD and how they change over the cycle. So this is work that Haley led on, which was the first analysis of this 10-week remote follow-up study. And she was focusing on sleep and identified that ADHD had greater variability in sleep features, various sleep features there versus the controls. And Heat then went on to look in that same data at various kind of phone usage behaviors for participants. So this is looking at things like questionnaire notification response latency, so how long somebody took to respond to a questionnaire, the time intervals between questionnaires, so how long somebody, would leave a gap between questionnaires, things like ambient light, and the social and communication apps that people were using, and the gap between kind of receiving a notification and responding to it, as well as things like steps, number of new apps added to the phone, etc. And so getting some really nice, interesting results coming out of that. I won't talk any more about that. I'll just leave that to Heath. And then some work that's been done on the early work on the TIMESPAN or ART Karma data. Here's looking at the real world consequences of ADHD medication in adults, and including changes in core symptoms, co-occurring psychiatric and emotional symptoms, physical measurements and patterns in daily movement and sleep, and seeing whether the effects of the ADHD measures or medication vary as a function of time with continued medication use. So some really nice results starting to show out here. And this is kind of in the 3-month follow-up period to following the investigation of medication. And so core ADHD, some key findings: core ADHD symptoms and functional impairments improved, with some evidence of kind of incremental improvements over their first 3 months of treatment. And the co-occurring psychiatric and emotional symptoms also improved. And we're seeing reductions in weight and waist circumference. And I think Yona was saying just at lunch that actually its weight takes a little bit of a lead in, and then we'll see those improvements. So as you might expect, there's an initial delay. It's not kind of immediate. And then I just want to close out with thinking about a couple of things. So this is actually a paper published last year, where we're using the platform, and actually rather than just kind of tracking, and we're actually using it in a trial. So this was an NIHR trial, where it was the intention was to collect various kind of measures from individuals without devices, or kind of periodically collecting heart rate. But we augmented the trial and gave people Fitbit devices, and then collected information through the apps and the Fitbit devices. This meant that we were able to collect 2 to 3 million heart rate data points per patient over this 20-week period, where we're comparing medications or response to medications for digoxin versus beta blockers. And we actually found that, so it was really useful, this, because it meant that we had a really kind of fine-grained handle on how these medications were working in this trial and the response to them. But also we're able to build a model of wearable sensor data that showed similar to performance for predicting future health status as conventional measures used in clinical trials, and those the kind of clinical assessments. And so this is this is just, I've just spoken about the mobile health element of the work that we do as a group and as our collaborators do, but actually it feeds into a much kind of larger ecosystem of work. And this includes information from the electronic health record, as well as kind of bioresource type information. And a critical component to this work is getting information back into care. And some of the recent work that we've been doing to enable this has been through the apps and through radar-based consenting people for the linkage to the electronic health records and the healthcare system data, and the collection and retrieval of the NHS ID in the UK to enable that. And we're very much moving towards taking advantage of the opportunity presented through the advances in generative AI and foundation models. And we built over the past few years foundation models of electronic health records. And looking now, we're starting to see that, I mean, you're all used to seeing things like ChatGPT and those kind of language-based LLMs. Those same kind of technologies can be applied to electronic health records. And we have done that here. but also we're starting to see those approaches being applied to wearable and phone type data. And of course, we're moving to the stage that we want to be at the stage where we could combine this wearable and phone data with the kind of routine healthcare system in a single multimodal foundational model of health. So in summary, we have the radar-based platform, which is open source, live monitoring, scalable and extensible, conforms to open standards, and a number of channels here for you to, if you're interested in using that. It's being used widely, globally. This is just some of the things that we're aware of, but obviously a lot of people doing things with it that we're not aware of. We provide, you can grab it from here. And we also, as I mentioned at the start, we now provide a service around this, enabling you to kind of take things off the shelf, and we can spin a study up for you, and then you can deploy that into your programs. And so finally, just to recognize the group that we're part of here, the Precision Health Informatics Data Lab, which is within the Department of Biostats and Health Informatics at King's, also within the Institute of Health Informatics at UCL. Strong collaboration with Yona and her team, and the key players within this work on our side are here. And thank you to various funders and partners, and mostly, finally, but not leastly, to all our patients, participants, and contributors and carers. Thank you.